Hello everyone, it's my great pleasure to give this talk about fibrates and other PPAR modulators for the treatment of primary biliary cholangitis. Here are my links of interest. Peroxisome proliferator activated receptors, or PPARs, are a family of three nuclear receptors, PPAR alpha, PPAR delta, and PPAR gamma, that play a key role in the homeostasis of lipids, glucose, and energy, as well as in the regulation of inflammation. PPAR agonists have been specifically developed and approved for the treatment of dyslipidemias and diabetes. Fibrates are all lipid-lowering agents. They are potent PPAR alpha agonists, except for bezafibrate, which is a pan-PPAR agonist. They have no or weak affinity for PPAR gamma or delta. They increase fatty acid oxidation and energy expenditure. They decrease LDL cholesterol. They decrease bile acid neosynthesis, and they decrease inflammation, but they have no significant effect on glucose metabolism. The first observation of a beneficial effect of fibrates in PBC came from Iwasaki and colleagues in 1999. In this study, the Japanese authors showed that treatment with bezafibrate was associated with a dramatic decrease in biomarkers of cholestasis and specifically in alkaline phosphatases in both UDCA resistant on the left and UDCA naive patients on the right. Fibrates are assumed to exert their effects in PBC through three main mechanisms. First, they inhibit CYP7A1, the limiting enzyme of bile acid neosynthesis, therefore reducing bile acid overload in the liver. Second, they decrease bile toxicity by stimulating MDR3 expression and phospholipid secretion into bile. And finally, they decrease inflammation by repressing NF-κB in the liver. Confirmation of bezafibrate efficacy in PBC came from the BEZOSO trial published in 2018. This trial was a 2-year placebo-controlled study of bezafibrate, including 100 patients with an incomplete response to UDCA according to the Paris 2 criteria, and randomly assigned 1-to-1 to bezafibrate 400 mg per day or placebo. The primary endpoint was the percentage of patients with a complete biochemical response defined by normal levels of total bilirubin, alkaline phosphatases, transaminases, albumin, and INR. At the end of the study, as shown in the histogram, the percentage was 31% in the bezafibrate group and 0% in the placebo group, which was highly significant. Here are the courses of alkaline phosphatases, total bilirubin, and alanine aminotransferases according to treatment groups. All these liver function tests were significantly improved in the bezafibrate group as compared to the placebo group. The effect was detectable as early as month 3 for alkaline phosphatases. Bezafibrate has also been associated with a significant improvement of PBC-related pruritus, as shown by these observational data from the Barcelona team on the left, which have been recently confirmed in the randomized FITCH trial from the Amsterdam group on the right. The safety profile of bezafibrate in PBC does not differ from that described in dyslipidemias. In the BEZOSO trial, the most frequent side effect was myalgia, which was reported in about 20% of patients. Significant increase in transaminases, possibly related to bezafibrate, was observed in 6% of patients. Finally, A stable 5% increase in creatinine level was observed in the bezafibrate group as compared to the placebo group. Long-term outcome of bezafibrate in PBC has been assessed from a large cohort of Japanese patients diagnosed and treated after 2000. Approximately 20% of these patients had been treated with bezafibrate in combination with UDCA because of an incomplete response to UDCA alone. After adjusting for the main prognostic factors at baseline, exposure to bezafibrate, assessed as a time-dependent variable, was associated with a 65% significant reduction in mortality or need for liver transplantation. This association remains significant in the different risk groups assessed at baseline. In difficult-to-treat PBC patients, the combination of fibrates with obeticholic acid has recently been shown to improve and even normalize prognostic biomarkers, specifically alkaline phosphatases, with a 3.4 odds ratio of achieving normalization of this parameter as compared to dual therapy. Addition of fibrates to obeticholic acid in this study was also able to improve pruritus significantly. PPAR agonists other than fibrates are currently under investigation in PBC. Ciladelpar, a PPAR delta selective agonist, elafibranor, a PPAR alpha delta dual agonist, and saroglitazar, a PPAR alpha gamma dual agonist, have all achieved efficacy endpoints in phase 2 studies with a good safety profile. All of them have shown significant capacity in reducing alkaline phosphatases over 12 to 52 weeks. Two of them, ciladelpar and elafibranor, have also shown to improve pruritus. So in conclusion, dear colleagues, bezafibrate, a pan-PPAR agonist, has proven beneficial effects on PBC prognostic biomarkers and PBC-related symptoms in both UDCA-resistant and UDCA-naive patients. Long-term exposure to bezafibrate in PBC patients has been associated with improved transplant-free survival. The main side effect of fibrates in PBC patients is myalgia, which is observed in about 20% of patients. In the first months of fibrate therapy in PBC, specific attention should be paid to the monitoring of creatinine and transaminases. Combination of fibrates with obeticholic acid is able to improve prognostic biomarkers and symptoms in difficult-to-treat PBC patients. Finally, new selective or multiple PPAR agonists currently under investigation in PBC have shown encouraging results. I thank you for your attention.